Thank you for the introduction and opportunity to speak today. I am Jake Miller. I'm one of the fourth-year residents over at UCI. Today I'll be presenting instead of Dr. Jeffrey Lee, who unfortunately was unable to make it. And I have no financial conflicts of interest to disclose, although some members of our team have served as a speaker for the team that makes Optilume. So as some of the prior speakers have discussed, recent studies have postulated that there's a growing interest in the preservation of sexual function in men seeking treatment for symptomatic BPH. A growing portion of this literature has examined the impacts of the various treatment options available for BPH. Now, in one such meta-analysis shown here, significant number of patients experienced retrograde ejaculation after standard treatments, including TURP, aquablation, HoLEP, and vaporization therapies. In this study, minimally invasive surgeries that we've discussed, such as UroLift and Rezūm, showed no association with significant rates of retrograde ejaculation or worsening sexual function. However, in this specific study, there weren't sufficient data at that time to allow for a pooled analysis. And so Optilume BPH catheter system represents a possible third option in addition to these prior treatments, UroLift and Rezūm, in the treatment of symptomatic BPH with a focus on the preservation of sexual function. This treatment is a novel, minimally invasive surgical therapy, which functions through the dilation of the prostate and creation of an anterior commissurotomy using a two-balloon system. The second balloon is a drug-coated balloon using paclitaxel coating, theorized to prevent a hyperplastic response following therapy to prolong treatment effects. Now, as Dr. Yaffe showed, there are primarily two key studies examining the sexual function outcomes for Optilume. The first being the Pinnacle study shown here. In this trial, 148 men with symptomatic BPH with prostate sizes up to 80 grams were randomized in a 2-to-1 fashion, Optilume versus sham. Now, 12 months follow-up, the Optilume arm saw a significant decrease in IPSS scores by an average of 3 to 4 points versus the sham. And in this group, only 4.1% noted ejaculatory dysfunction, with no statistically significant changes compared to sham. In the second key trial, the Everest study, 80 men were followed with symptomatic BPH in a prospective single-arm trial for up to 4 years of follow-up. Now, at this time, 78% of men following treatment noted symptomatic responses defined by at least a 30% improvement in IPSS scores. And similarly, no statistically significant changes were noted in sexual functioning between pre- and post-treatment questionnaires. And so to demonstrate the use of this device in video, we present the following case of a 67-year-old man with history of symptomatic BPH refractory to medical management with a prostatic volume of 50 grams. For the procedure, standard equipment for rigid cystoscopy is employed with a minimum sheath size of 19.5 French. An additional 100 milliliters of sterile water is used for catheter inflation, which will either be a 20 French 2-way catheter or 22 French 3-way catheter. Lastly, the system comes with both a pre-dilation and, again, drug-coated balloon, along with all of the necessary equipment for inflation afterwards. Overall, the procedure can be performed under local anesthesia, general anesthesia, or MAC, and includes cystoscopy for lower urinary tract assessment, dilation and creation of the anterior commissurotomy with the pre-dilation balloon, and lastly, use of the drug-coated balloon. The transrectal ultrasound, or MRI, may be used to measure the prostatic urethral length, and this is important when selecting the appropriate catheter size. As of now, there are currently 4 catheters depending on urethral length. Now, in these next 2 slides, before going into the video, we have the detailed steps listed for reference if anyone would care to have that afterwards. However, we can proceed with the video. So again, the procedure starts with a cystoscopy to assess the lower urinary tract. Again, this can be performed under various levels of anesthesia. In this patient, we performed it with MAC, using specifically IV midazolam and fentanyl. In this patient, MRI was used to estimate the patient's prostatic urethral length and to select the appropriate catheter size. Now, in this case, the prostatic length was 4.5 centimeters, and so we elected to choose the 90 French by 4 centimeter balloon. Now, after removal of the working bridge, the pre-dilation balloon is inserted to the level of the bladder, followed by removal of the outer sheath. The cystoscope is then reinserted alongside the placed pre-dilation balloon to confirm its positioning, with that blue marker seen there positioned lying at the distal edge of the external urethral sphincter. The balloon is then connected to the dilation device and inflated up to 3 to 4 atmospheres of pressure. Now at this point, there will either be a sudden drop in pressure, as seen on the pressure gauge, or visual bleeding seen cystoscopically, which can signify that the anterior commissurotomy has been achieved. After 1 minute of inflation, the balloon is deflated and removed, and at this time you can advance the scope towards the bladder to confirm that an adequate commissurotomy has been achieved, which you can see on the screen with the anterior splitting of the mucosa. Now following this, the scope can be re-advanced into the bladder, and then similar steps can be followed to insert the drug-coated balloon. Prior to the insertion of the drug-coated balloon, care should be taken to avoid submerging the balloon into irrigation fluid or aggressively rubbing the catheter as a way to avoid removing the paclitaxel coating. Again, the cystoscope is advanced to confirm the positioning of the drug-coated balloon, with the blue marker again ideally sitting at the level of the external urinary sphincter. In this case, the drug-coated balloon should be allowed to rehydrate for about 1 minute prior to inflation. During this inflation, the scope can be removed, and the balloon will again be inflated up to 3 to 4 atmospheres of pressure. This time, the balloon will remain in place, inflated for a period of 10 minutes. Now, following this 10-minute period and following the deflation and then removal of the balloon, a 20 French 2-way or 22 French 3-way catheter is inserted and then secured with 100 milliliters of sterile water. The bladder can then be irrigated until clear fluid is seen when aspirated without clots. Catheter traction may be used up to the physician's discretion, and in this specific case, it was applied for 1 hour postoperatively, after which the patient was discharged with the catheter in place for a period of 2 days. And so again, in this case, the patient was discharged shortly thereafter with medications including anti-inflammatory and anticholinergic meds. They were subsequently seen 2 days later in clinic, and at this point had their catheter removed and passed a trial of void. They were seen a few months later, at which time they noted significant reduction in their lower urinary tract symptoms without concerns for sexual dysfunction. Thank you again, everyone, for the opportunity to present this new treatment, and we look forward to the discussion to follow.